So, now we're moving on to Chapter 3, Heart-Lung Interactions in Health. So this is the graphical integration of heart-lung physiology that I just showed you. The cardiac function curve moves along the x-axis following intrathoracic pressure changes, and we can therefore have a three-dimensional analysis that relates the intrathoracic pressure to cardiac output and changes in lung and chest wall compliance, which is depicted on the z-axis directed into the page. So this is what I just showed you. From this you can get a graphical representation of the transmural pressure. So this is at FRC before you've inspired. So this is again a marker of your intrathoracic pressure here. And then this is your intravascular pressure. This would be like if you were measuring the CVP, the pressure within the right atrium, less the intrathoracic pressure. This gives you the distending pressure of the right atrium, which is a marker of right atrial volume. With inspiration, there's a change in intrathoracic pressure that follows the static and dynamic properties of the lung as illustrated on the Campbell diagram. So you move from here to here. So you've changed your intrathoracic pressure now, and so how does the cardiac function curve change? Well, we just saw. It follows, it shifts to the left, and you have a decrease in your right atrial pressure, an increase in your transmural pressure, and this is what happens when you inspire, as graphically represented by the Guyton and Campbell analyses. And then in Chapter 3, what we go through is we look at volume and pressure effects on the cardiovascular system. And I'm using this Venn diagram here to illustrate this. So remember that the Campbell diagram relates thoracic volume and pressure. So this Venn diagram is actually recapitulating the Campbell diagram, and it helps us tease out and make more digestible some of the complicated and sometimes conflicting results of changes in intrathoracic pressure and lung volume on cardiovascular system. And so basically Chapter 3 follows this Venn diagram of what are the effects of just an increase in lung volume on the cardiovascular system, what is the effects of only a decreased intrathoracic pressure on the cardiovascular system, and that's also known as a Mueller maneuver, as you may have heard, and then what's the effect of a decrease in intrathoracic pressure and an increase in lung volume simultaneously, and as you obviously know, that is a spontaneous breath, and that can be looked at via the Campbell diagram. Conversely, you can look at what only an increase in intrathoracic pressure without an increase in lung volume does to the cardiovascular system, and as we know, this is the Valsalva maneuver. And then the two of these combined, an increase in lung volume and increase in intrathoracic pressure, is the effect of an intermittent positive pressure breath with or without the application of end expiratory pressure. And so I came up with this hypothetical situation as just an example from Chapter 3, is what happens if we could just increase lung volume without a change in intrathoracic pressure. So looking at the Campbell diagram, that would just be only an increase in the z-axis here without any lateral change in intrathoracic pressure, and then superimpose that on the cardiovascular system as illustrated by the Guyton analysis here. So the effect of an increase in lung volume will have a change in your venous return. It tends to increase your mean systemic pressure because as the diaphragm drops, you pressurize the abdomen and you tend to recruit unstressed and distressed volume and increase your mean systemic pressure. So you increase your mean systemic pressure, which increases the pressure head for blood return to the heart. But it has variable effects on the resistance to venous return. Here, there's an increase in the resistance to venous return, and here there's no change in the resistance to venous return. And what determines resistance to venous return is something that was described by Takata and colleagues in the mid-90s, and that is it depends on your underlying volume status, and particularly in your abdominal vessels. And they actually applied West zone physiology of the lung to the abdomen, and patients who were volume up, hypervolemic, tended to have West Zone 3 physiology in the abdomen, so they did not have an increase in the resistance to venous return, whereas patients who are U or hypovolemic tended to have West Zone 2 physiology in the abdomen, and that tended to compress the vessels and increase the resistance to venous return in the heart, and it rendered the venous return curve in this fashion. And then increase in lung volume can actually have variable effects on right ventricular afterload. So if you increase right ventricular afterload, which is determined by how high the lung volume goes above FRC, because remember that pulmonary vascular resistance is a minimum at FRC, and it increases below FRC and it increases above FRC as you compress the pulmonary vascular bed by the increase in lung volume, and that tends to afterload the right ventricle. And as we saw, that would tend to shift the cardiac response curve somewhat down and to the right. So you can see you have this variable array of effects based on just a change in lung volume, comparing these points here and these points here in terms of what your right atrial pressure and cardiac output would be for just an increase in lung volume. And then in Chapter 4, I go through a number of different disease processes, heart-lung interactions, and sickness. And one of them I'm going to describe for you here can explain some conflicting results that have been seen in ARDS and changes in right ventricular volume. Some studies have shown that right ventricular sizes increased. Some have shown that right ventricular sizes decreased with the application of end expiratory pressure. And I think something that can help explain some of these disparate results is this paper in the Blue Journal in the late 90s by Gattinoni and colleagues, and he proposed this distinction between pulmonary ARDS, which was an extra-pulmonary ARDS, which were patients who were in ARDS and then determined by clinicians whether this was a direct toxic insult to the lungs, for example, a bad aspiration pneumonia or a bad pneumonia, versus intra-abdominal sepsis or trauma, pancreatitis, which are diseases outside of the lungs which can lead to ARDS, and those patients were labeled as extra-pulmonary ARDS. In both states, there's a drastic reduction in the compliance of the respiratory system, so you see high peak and plateau pressures. But what was interesting in that paper is they found that in pulmonary ARDS, the abnormality of the impaired respiratory system compliance was almost entirely from poor pulmonary compliance. And in these patients, the histopathology was largely consolidation. And the application, because of the poor pulmonary compliance, application of ventilatory pressures led to a large increase in the transpulmonary pressure. Remember, the transpulmonary pressure is your alveolar pressure less your pleural pressure. So if you have very stiff lungs, your alveolar pressure will go up out of proportion to the increase in pleural pressure. The pleural space is seeing less of that airway pressure being transmitted to the pleural space, so the transpulmonary pressure goes up. And what's important to realize there, that transpulmonary pressure is really a major determinant of right ventricular afterload, and you can sort of appreciate that as transpulmonary pressure goes up, the alveolar pressure less the pleural pressure, then you're going to have compression of pulmonary venous beds, and you'll essentially create West Zone 2 physiology as your transpulmonary pressure goes way up. So this elevation in transpulmonary pressure afterloads the RV. That's what I'm saying here. So in contrast, the extrapulmonary patients, the abdominal sepsis, the trauma, pancreatitis, they had a low respiratory system compliance, but it was primarily driven by a low chest wall compliance rather than a low pulmonary compliance. And it tended to track the increase in intra-abdominal pressure that was seen in these patients. And histopathologically in the lungs, these patients tended to have more interstitial edema and atelectasis that was actually recruitable. And basically the drop in respiratory system compliance was driven by the chest wall. So what this does is, and I'll show you pictorially in just a moment, is that the reduction, because the pleural pressure follows, and we talked about this in Chapter 1, because the pleural pressure follows the chest wall compliance curve, the lowering of the chest wall compliance tends to result in a high pleural pressure and actually a low, therefore a low transpulmonary pressure. So you can imagine that these patients would have a lower right ventricular afterload because the transpulmonary pressure is lower, and a higher pleural pressure, which would actually tend to compress the right ventricle and right atrium and actually shrink right ventricular size. So just graphically, how does this look? Well, let's talk about pulmonary ARDS. So this is a shift down and to the left of the pulmonary elastance curve. This is the bad pneumonia patient, bad pneumonia ARDS. So there's an increase in the distance between the lung and chest wall elastance curves, and as we saw in Chapter 1, this results in an impaired respiratory system compliance. So graphing this distance with lung volume, you can see that if this is the normal respiratory system compliance, you've now created a respiratory system compliance like this. So this explains why their plateau pressures go way up. But the pleural pressure will follow the chest wall elastance curve, and because these patients did not have much of a change in their chest wall elastance, there's not much of a change in their pleural pressure. It's mostly the plateau pressure. And the plateau pressure is a surrogate for your alveolar pressure at end inspiration. So you can see that because your alveolar pressure less your pleural pressure is your transpulmonary pressure, the lateral distance between this curve and this curve actually represents your transpulmonary pressure. So your plat goes up, but your pleural pressure does not. So this is a representation of an increased transpulmonary pressure. There tends to be an increase in airways resistance with ARDS as well, so peak pressures will go up, and this is the dynamic curve that we talked about in Chapter 1. So what about extra-pulmonary ARDS? Well, that's a drop in the chest wall elastance curve, so that shifts down and to the right. There's an increased lateral distance between the two curves, so graphing them you see there's a decrease in the compliance of the respiratory system, but because pleural pressure follows the chest wall elastance curve, the difference between a plateau pressure, or your alveolar pressure, and your pleural pressure is actually much less. This is your transpulmonary pressure again, and a lower transpulmonary pressure would tend to result in a lower right ventricular afterload. So it should be easier for the right ventricle to unload, coupled with the higher pleural pressure, which will tend to compress the right ventricle, so you'd expect these patients to have a lower right ventricular volume. And that's actually what's been shown by Jardin's group, I believe, in Paris, looking at velocity time integrals across the pulmonic valve in patients with ARDS, pulmonary ARDS, and then they actually bind the patient's chests to decrease chest wall compliance, and have shown that the velocity time integral actually increases as a marker of decreased right ventricular afterload. So in this patient, the difference between the pleural and the plat is actually quite narrowed. So this is a marker of transpulmonary pressure and therefore right ventricular afterload. So what this is this is the Campbell diagram going into the z-axis. It's supposed to be going into the page. This is the chest wall elastance curve, which, as I mentioned in the previous slides, in pulmonary ARDS is not really affected. The chest wall elastance curve remains the same slope. I've removed the pulmonary elastance curve from this diagram for simplicity, but because this is pulmonary ARDS, as I mentioned, the pulmonary elastance curve is going to be shift down and to the left. So it would sort of begin here at its equilibrium volume and then bend out in this direction here. And so FRC is here, and the reduction in the pulmonary compliance leads to a reduction in the compliance or the elastance of the respiratory system, and that's highlighted by this curve here. This additional curve to the right of the respiratory system, static compliance curve, is the additional amount of pressure that must be applied by the ventilator to overcome airways resistance. And again, this curve here, this may be a little bit confusing because this is the x-axis is pressure, and this is really following pleural pressure along the elastance curve, or the pulmonary elastance curve. This curve, by contrast, while the x-axis is still pressure, This is actually airway pressure. This is the pressure that's being measured at the proximal trachea by the ventilator itself. So what I'm going to do is I'm going to run through the application of PEEP on the respiratory system here. And so you're going to start at FRC, and remember, as I mentioned, in the passive paralyzed patient, some nice alliteration for you, in the passive paralyzed patient, the pleural pressure follows the chest wall elastance curve. So starting at FRC, the application of PEEP will increase your pleural pressure, but not really to a great amount in this patient because they have normal chest wall elastance. And you'll see the comparison with extra-pulmonary ARDS in the following slide. So you've increased your pleural pressure with the application of PEEP, and at the same time, if you were to measure a plateau pressure in this patient with the application of PEEP, the plateau pressure, that is the proximal airway pressure, would be way up here. So this difference between and that's essentially, your plateau pressure is essentially a surrogate for your alveolar pressure, that you can imagine this static column of pressure from your alveolus all the way up to the proximal trachea when there's no airflow. So remember, the alveolar pressure less the pleural pressure, this is the distending pressure of the lung, or the transpulmonary pressure. And it is the transpulmonary pressure in multiple experimental paradigms has been found to be the right ventricular afterload. And you can sort of imagine that because it's the transpulmonary pressure that's determining the distending or crushing pressure of the pulmonary venous bed, the pulmonary capillaries, and really kind of the determinant of West Zone 1 versus West Zone 2 versus West Zone 3 physiology. And then this would just indicate an additional positive pressure breath, a transient positive pressure breath on top of the PEEP, and that would be a transient reversible effect. And again, but the PEEP is something that's constant because it's maintained throughout the respiratory cycle as a baseline expiratory pressure. So now let's just run through it with the superimposed Campbell diagram. Again, this is your venous return curve. This is your cardiac function curve, your right atrial pressure, your transmural pressure. So the application of PEEP is going to have predictable qualitative, not quantitative, effects on the right ventricle. The right ventricular cardiac function curve is shifted down and to the right to a certain extent because of the afterload that's imposed upon the right ventricle by pulmonary ARDS, say from hypoxemia and atelectasis. Now, I'm going to run through what we just ran through with the Guyton diagram here. If you apply PEEP, you're going to shift the cardiac function curve rightwards. And you're going to shift the cardiac function rightwards along the pleural pressure. Remember, the pleural pressure will increase from here to here. And you'll see that reflected in the shift in the cardiac function curve. Now, the cardiac function curve will also shift down and to the right, as I've illustrated here, because you've imposed this higher transpulmonary pressure, and you're essentially afterloading the RV here. Additionally, there's been some changes you can see in the venous return curve, and I'm not going to really get into the details of why that is here, but you can see the pressure at which you get venous collapse and maximal venous flow has increased from atmospheric pressure with the application of PEEP to supraatmospheric pressure. And this is more or less a function of the increase in pleural pressure and where you get vascular waterfall as the great vessels enter the thorax. Okay? And then if you were to impose an additional transient positive pressure on top, you'll get a worsening. I haven't graphed it here. Your transpulmonary pressure would get quite high with that transient breath. It would afterload the RV. It would shift the RV cardiac function curve down and to the right even more, increase your transmural pressure, and you can see the increase in the transmural pressure means that the RV is distending. So in the patients with pulmonary ARDS, because of the relative increase in right ventricular afterload relative to the increase in pleural pressure, you have the right ventricle having a harder time ejecting. You therefore have a higher right atrial pressure, a lower cardiac output, and you have an increase in your right ventricular volume. Now we're going to contrast that with extra-pulmonary ARDS, which is typified by a downshift in the chest wall elastance curve. This is the respiratory system compliance curve, and you can see the lateral distance between the two, or the transpulmonary pressure, is much diminished compared to the last patient. So running through what an application of PEEP would be, your pleural pressure increases to a greater extent than in the pulmonary ARDS patients, because the impaired chest wall compliance tends to transmit or tends to increase the pleural pressure to a greater extent. So your pleural pressure would increase, and then the application of a positive pressure breath on top of that would increase your pleural pressure transiently even more, and despite there being a much lower transpulmonary pressure in these patients. So now superimposing the Guyton analysis on this patient, application of the PEEP will shift the cardiac function curve to the right to a greater extent. So your transmural pressure will actually tend to shrink, and the lower transpulmonary pressure may actually afterload the RV, or reduce the afterload to the RV and facilitate ejection. So this would be a positive breath on top. And if you actually recruited these patients with PEEP, that is, they were atelectatic, and you improved the atelectasis with PEEP, you could actually improve right ventricular afterload, and the cardiac function curve may actually shift up and to the left a little bit, which would tend to improve cardiac output and lower intracardiac pressures. But again, these patients would be the ARDS patients whose right ventricular size would tend to shrink with the application of positive pressure, as opposed to the pulmonary ARDS patients who have a higher right ventricular afterload. You'd expect the right ventricle to distend in size with the application of positive pressure. So that's the overview. That is my not-so-brief overview of chapters 1 through 4. I hope you are intrigued, and I hope that you are excited, and then I hope that you are ready to watch more lectures and get educated in cardiopulmonary physiology in the intensive care unit. Thank you very much. See ya.